Welcome to the next evening lecture from PeMSAA. So what we showed you was a few pictures from some of the PeMSAA activities over the last few years, obviously not in COVID times, but before COVID times. So you can see that there's a lot of things that the PeMSAA does for the faculty, for the students. We organize a lot of workshops, and there are things that we can't do in COVID times. So we've switched to online mode, which is why you are having these lectures online. Otherwise, those days when we were students, we used to have the evening talks on Thursday evenings from 7 o'clock onwards. We used to have these talks in the physiology lecture theatre, and we used to always look forward to them a lot. So the PeMSAA is a very, very active society. It's the Peradeniya Medical School Alumni Association. It is the oldest alumni association in a medical school in Sri Lanka. And we would be, so currently I'm the secretary, Professor Tushara Kuragammana is the president, and we would be, Dr. Gominda is the associate secretary, and he has been organizing this program for you all. Dr. Ruan from biochemistry is the other associate secretary, so he has also been helping in organization. So we would be very happy if you would like to join the PeMSAA as associate members, because you all will be graduates very soon, within a year or two or even less. You all will be graduates, you all will be alumni of Peradeniya. So we will be very happy if you all would like to join the PeMSAA as associate student members. You are welcome to. You can do so online. You can go to the PeMSAA website and all the instructions are there. You can pay online, and it's just 500 rupees. You can send the receipt and you can join, or you can go, once you all get back to faculty, you all can go to the PeMSAA office, which is behind the dean's office in the back, in the department, in the building behind the dean's office, and you all can join there as well. And it's a great way to keep in touch with batchmates. There's biannual congress, and you get to meet all your batchmates and the seniors and juniors again. And there's a continuous medical education process going on. And there are a lot of different activities. Currently, we are involved in getting the faculty, a beautification project to get the faculty looking nice again. As there are social activities like the Christmas carols and Bhaktigi and many other projects that go on. So it's not just academic, it's social and interactive and a close community. So we'd love to have you all join us, because we are just like you. We are alumni of Peradeniya, and so are you very soon. So we'd love to have you join us. So please consider joining the PeMSAA. Now on to today's lecture. So today's lecture will be delivered by Dr. Asanaka Nugaliyadda, and she is also, as always, an alumnus of Peradeniya. She is from the 99-2000 batch, so a few years senior to me. She graduated with honors, with second-class honors in the final year. She's got distinctions in biochemistry, pharmacology, microbiology, parasitology, ComMed, and Path. After qualifying as a rheumatologist, she has worked in Matale, Navalapitiya and Ampara, and she is currently practicing in Matale. And she is a wonderful teacher and a wonderful rheumatologist, and I'm sure she's got a lot of things to teach you, and I'm sure she's a very friendly person. She's very approachable, and she's someone who you can really ask a lot of questions about, especially about obviously the rheumatological problems that you have seen in the wards, or about the cases that you think, because rheumatology cases are very common both in pediatrics and in medicine. So without further ado, Dr. Asanaka, I invite you to take over with the presentation.
Thank you, Champa.
Thanks, Akka. It's very nice to see you again. If you would
after
years and years.
Yes, after years and years. It was so nice to see those pictures. Screen share. Right. Good evening, everybody. To give you all an overview of how to approach a patient presenting with arthritis, and also to give you a basic idea of the types of arthritis, and also give you how to take care of these patients. But before I start, I have to teaching medical students. If you think this is too basic or too much of rheumatology, if you want me to tone it down, it's the information of joints and associated tissues. So categories. So that is inflammatory and degenerative. So the inflammatory arthritis is where there is prominent inflammation. So the most common, that is rheumatoid arthritis, and we have the spondyloarthritis. I will elaborate on these topics later. So then we have the that is like scleroderma, then mixed connective tissue disease, and also diseases like sarcoidosis and so on. And then we have the crystal arthritis, that is the gout and pseudo gout, and also the infection-related arthritis, that is septic arthritis. So acute bacterial, maybe TB, the arthritis which comes as reactive arthritis, that is post-infectious arthritis. And also we have the other category, that is the degenerative arthritis. It is due to the degenerative process of the joints. But there is, of course, you have to remember that there is some inflammation associated with this arthritis as well. So just to touch on a few terms that we use in arthritis. So monoarthritis is when a single joint is involved in this process. And then so polyarthritis is symmetrical. So when we say symmetrical, it does not have to be absolute symmetrical. So you don't expect the arthritis to involve the second metacarpophalangeal joint of the right hand as well as in the left. So it is like the pattern of involvement. So whether there are small joints involved in both sides or large joints involved. So, so which small joints, whether it's the metacarpophalangeal joints or the proximal one. What is meant by symmetry is you have to have the similar joints involving on both sides. Then the other term that I want to introduce you to is the interstitial side, the tendons, ligaments, the fascia and joint capsules insert into the bones. So enthesitis is when there is inflammation of these sites. So I thought I'd discuss this, I'll do my lecture in a case-based discussion, because I thought that would help you help you get an overview, a better idea this way. So the first patient that I'm going to discuss is a 45-year-old lady, pain and swelling of small joints of the hands, knees, elbows with morning stiffness of 1 month's duration. She also has fatigue. And hold on. She also complains of fatigue. And then on examination, you can find there is on examination, you see the swollen and tender metacarpophalangeal joints, interphalangeal joints and knees. So you do the systemic examination, rest of the examination is normal. So here the metacarpophalangeal joints are swollen. And then you see the proximal interphalangeal joints. So when you exert mild pressure over these joints, you can demonstrate tenderness. So what are your differential diagnoses for this patient? So the first differential diagnosis is rheumatoid arthritis. And it could be other systemic rheumatic disease related arthritis as well, which is presenting with this symmetrical. So let's go back to the previous slide. So this is symmetrical arthritis. So this patient has proximal interphalangeal joint involvement and metacarpophalangeal joint involvement. So this is symmetrical polyarthritis involving the small joints. So we think of rheumatoid arthritis, and then we think of systemic rheumatic disease related arthritis, like that is associated with SLE and so on. So it can also, this kind of picture you can get with psoriatic arthritis and also viral arthritis. But here in this patient, had rheumatoid arthritis. So how do we get about this? So we have to look for other sort of the extra articular involvement, because rheumatoid arthritis, you can have extra articular involvement. So you have to auscultate the lung and see whether there is any lung involvement, and then you have to look at the skin carefully to see if there are any features associated with skin involvement, because they can have eye involvement. So you have to pay attention to the extra involvement as well.
Dr. Asanaka, is it okay if I interrupt you for a minute?
They can have cardiac involvement at the very beginning. Yes. Is it better now?
Yes, it's much better now.
Okay. So shall I start from here, or do I have to go back?
Students, what do you want? How was your signal?
Madam, the extra articular manifestations from there.
From there onwards. Is
okay.
that? Shall I start here?
Yes, madam.
Okay. So in rheumatoid arthritis, apart from the arthritis, you can have this extra articular involvement as well, right? So the commonest one is lungs and skin. So you have to look for these involvement as well, right? So in the lungs, you can get pleural effusions, then interstitial lung disease. So you have to auscultate and see, right? And then in the skin, you can get this rheumatoid nodules, especially in those patients with rheumatoid factor positive patients, right? And then they can get ulcers, mainly due to vasculitis. So these, of course, come later in the disease, not in the at the beginning, right? Then they also can have eye involvement, can get episcleritis, scleritis, and keratoconjunctivitis. And then they can have cardiac involvement like pericarditis. These also occur later on the disease, right? And then they are more prone to get coronary artery disease, and then they get vasculitis. Vasculitis usually occurs after 10 to 15 years, right? So then they can have neurologic. The carpal tunnel is quite common with the early rheumatoid arthritis. So you have to look for these as well, right? So how do you investigate these patients? So you have to do the basic investigations. So you do the full blood count. What can you find in the full blood count? So usually there's a anemia, that is anemia of chronic disease, and also thrombocytosis. Thrombocytosis due to the inflammatory condition, right? And then you do the liver functions. That is because now you are diagnosing rheumatoid arthritis, you will have to start them on treatment. So some of these investigations you do to sort of plan your treatment, or to help you in deciding which drugs to start, right? And then you have to do renal functions with UFR. Why do we have to do a UFR? That is, you can get a similar picture in other diseases like SLE. So we have to sort of screen for the presence of other systemic rheumatic diseases. And we have to get a chest X-ray as well, because if we diagnose rheumatoid arthritis in this patient, we need to get a chest X-ray, because we are going to start her on disease-modifying treatment. For that, we have to have these basic investigations. So we do the ESR CRP, which we find typically elevated. So they are usually elevated around 40 to 100 like range. You get the elevation of the ESR. And then you do rheumatoid factor. So mostly you can, about 40% you get rheumatoid factor positive. So rheumatoid factor can be positive in other conditions as well, but if it is more than 3 times the upper normal, then it's significant positive. And then, but with the clinical picture of the symmetrical arthritis, then a positive rheumatoid factor is very supportive of the diagnosis of a seropositive rheumatoid arthritis. Then we can go for anti-CCP antibody testing. That, of course, it's available here, but it's quite expensive. But here, because of that reason, we reserve it for the patients who are negative for rheumatoid factor, and when we have diagnosis, like when we're not sure of the diagnosis. But anyway, anti-CCP antibodies will be positive, and it's more specific than the rheumatoid factor. So if you have a significant positive anti-CCP antibody titer, that is very suggestive of rheumatoid arthritis. So management. So what we have with rheumatoid arthritis, what you have to do is we have to diagnose it early. We have to make the diagnosis early, and we have to initiate disease modifying treatments early, because if we delay it, the prognosis will be poor. That means the joint damage will be more, and the patient will need more and more higher doses of disease modifying agents and prolonged treatment to control the disease. So if the earlier you diagnose and initiate the disease modifying agents, the better outcome you get. And so we start off with a short course of moderate dose of steroids to control the disease, because disease modifying agents, they take time to act. So initially what we do is we give them a short course of moderate dose of steroids. So we don't give very high doses, we give 10 to 20 steroids. Prednisolone would be enough for these patients. And then we start on disease modifying agents. So DMARDs means disease modifying anti-rheumatic drugs. So the drug of choice is methotrexate. So we have to start them on methotrexate, but if there is any contraindication or if the patient is intolerant only, we would go for the second line ones. That is leflunomide. And then we have to give them analgesics initially, because we need to relieve them of the symptoms. And then we have to monitor the patient regularly. So we have to monitor the patient for drug side effects, because methotrexate can have side effects. So we have to monitor them for that. And also we have to monitor the disease activity. So we have to see whether they are responding to the dose of methotrexate that we have been giving the patient. So then if the patients are not responding, we have to escalate the therapy slowly. Gradually we escalate the therapy. So we increase the dose gradually and see if the patient is tolerating the dose and if the patient is responding. So if the patients are not responding, so we plan to control the disease as quickly as possible, so that then only we will get a better outcome. So if they are not responding to this monotherapy alone, then we add the second line agent. So that is sulfasalazine and hydroxychloroquine. So it is a continuous thing. We can't start the patient on the disease modifying agent and then we can't stop. We need to monitor them and see them regularly and titrate the doses. So when we treat them, if they are not responding, so we give them about 6 months to see if the disease is coming under control. And if it's not coming under control, we have the biologic disease modifying agents. So there are various types. So I'll just give you the names, or it's sort of like an idea. So we have this TNF alpha inhibitors. We have so this is widely used. So there are many types. So we have infliximab. So there's some of them are antibodies and some of them are receptor antagonists. So we have infliximab, etanercept, golimumab. I have not given you the names. I did not think that you would need them at this level. So we have various ones and they are available, readily available. Some of them are IV drugs, some of them are subcutaneous drugs, right? So, and then we have anti-CD20 antibodies, that is rituximab. And then we have IL-6 inhibitors. You must be hearing about this very common, like very frequently now because of tocilizumab. This is tocilizumab. Because of corona, we use tocilizumab in the management of corona, so you must be hearing about it a lot. And then we have these co-stimulation blockers, Aspiration. So these three, anti-TNF-alpha antibodies, anti-CD20 antibodies, and IL-6 inhibitors are readily available in Sri Lanka. But they are quite expensive and they have a lot of side effects. So we have to carefully select the patients. And then we have another category that is the targeted disease-modifying anti-rheumatic drugs. They are the JAK kinase inhibitors. So we have tofacitinib, which is available here. Then you must be hearing about baricitinib again because of corona therapy. So just a few words on role of steroids. So steroids are used, we don't use long-term steroids in rheumatoid patients. So we use steroids at the initiation of therapy because the disease-modifying agents are going to take a while. So methotrexate take about 8 weeks, sulfasalazine takes about 12 weeks, so hydroxychloroquine also takes about 12 weeks. So to cover that period, we give them steroids. So steroids help to bring down the inflammation rapidly. And also when we are changing the disease-modifying agents. So when we are changing one disease-modifying agent to another, we have to use these steroids. And also acute flares. So during acute flares, we can use steroids for short, like they are all short-term pulses of steroids. And then the other use is the intra-articular. So we use a lot of intra-articular steroids when they have a single joint flare or single joint involvement. We use intra-articular, and also we can give intramuscular. So that will also, instead of giving oral prednisolone, we can give a IM methyl prednisolone that would sort of last for about a month. And then of course rarely we tend to use intravenous steroids as well, but that is when there's a severe flare which is very difficult to control. And then other therapeutic modalities that we have, physiotherapy to help in the acute setting, then we can use the hot and cold therapy. And then for long-term management also we need to give them physiotherapy because we have to teach them passive, so we have to give them passive and active exercises to keep the range of motion and to keep the muscle strength. And also we can use orthosis. I will show some pictures later on. And then occupational therapy, that's another important aspect of treatment. So occupational therapy is like they will prescribe splints for these patients. So we have active splints, passive splints, active splints and resting splints. So resting splints to be used when you have active disease, and then active splints to help you with day-to-day activities when you have this arthritis and deformities and problems. And then joint protection, that is we have to give them splints to protect their joints and also advice on how to protect their joints. I will show you in a couple of slides down what advices to give them for joint protection. And also we have assistive devices, that this is mainly for patients with chronic arthritis with deformities. So these are a few of the joint protection principles. So because rheumatoid arthritis involves the small joints, we should not put strain on the small joints. So we should not squeeze stuff. We should not put pressure on the joints. We should not lift weight. So we advise the patients not to open tight cans like this. They have to use the palm, and then we have to advise them not to put pressure on the fingers, to use the handle of cups in a proper way. Like that, there are several advices. So this is how to use a kettle. You use both hands instead of using one hand, because when you use one hand, the pressure, the weight on this one hand, it will be too large, too greater for one hand. So you use both to give less pressure, and this is how to hold a cup and how to hold weights. So these advices have to be given to these patients. This is because when there is arthritis involving these joints, then the joint capsule and the ligaments and tendons which keep the joint in place become lax. So that will so when you put too much pressure on the joints, that can lead to deformities due to subluxation and so on. So these are modified utensils and assistive devices. So patients who have problems holding spoons, we have spoons like this, and then you can use this device, these things to sort of make the grip larger, because they can't grip. Their pincer grasp is sort of grip is difficult when they have a small joint involvement. So you have these sort of devices to help them with cutting and holding. And these are some examples of spleens that are used. So this picture shows the early rheumatoid arthritis hand, and then intermediate and the late one. So if we initiate treatment early and give them proper management, we can prevent this from going into this deformed hand. So this is to show an X-ray. So you can see in the X-ray, this is a normal hand. Here in the late one, you have a lot of erosions, and the joint, there are subluxation of joints. So there's a lot of deformities here. So early initiation and control of the disease is the key to take care of your rheumatoid patients. So the second case is a 42-year-old male with diabetes, dyslipidemia, and hypertension. So this patient now presents with acute pain and swelling of knee joint for 3 days duration. So you can see it's grossly swollen, and there's restricted movements, and the joint is warm to touch, and there is a large effusion. The patient does not have fever or malaise. So the first differential diagnosis, the first thing that should come into your mind, or the first thing that you must exclude, is a septic arthritis, right? Because septic arthritis, it's very important that you diagnose it early and start treatment, because it can lead to sepsis, and also it can give rise to a lot of joint damage as well. So the other differential diagnosis is hemarthrosis. Then you have your crystal arthritis, the gout and pseudogout. They present just like septic arthritis. And of course, reactive arthritis can present with a monoarthritis. And then the first presentation of chronic inflammatory arthritis, that is spondyloarthritis or rheumatoid arthritis, also can present rarely with a single joint involvement. And also osteoarthritis flare. But here you don't get a gross inflammation, it's just a mild inflammation even in the flare with rheumatoid arthritis. So the first thing you must do in this situation is to exclude a septic arthritis. So you need to do a joint aspiration, and you have to do a full report culture. And also, if you have the facilities, you can send this for polarized microscopy to look for crystals. Because in our crystal arthritis, we can see the crystals. And you do the basic count, the full blood count, which to look for evidence of any infection, and then CRP. And then we also have to do the basic investigations, including the sugars, to see the general condition of the patient. So a few words on joint aspiration. We have to do the joint aspiration under aseptic condition. So this you must remember, you do not aspirate if it's a prosthetic joint, or if there's any sort of metal work in that joint, involving that joint, you don't do it. It needs to be handled by the orthopedic team, because it has to be handled in the theater. So we don't touch it. You inform the orthopedic team immediately. So a lot of people have this problem. Anticoagulation therapy is not a contraindication for joint aspiration. So I won't go into a lot of detail about septic arthritis. It's more of an orthopedic topic. So septic arthritis, I'll just touch on it. So we get this acute bacterial arthritis, and then we can have tuberculosis, then gonococcal arthritis. And then we have these predisposing factors. If it's a prosthetic joint, they're more likely to get. And if they've had, if they have had a procedure to the joints, like maybe joint injection or something prior to this, then that becomes a predisposing factor. And elderly are more likely to get septic arthritis, and also immunocompromised patients, and also previously damaged. So even rheumatoid arthritis patients with rheumatoid arthritis can get septic arthritis. So septic arthritis is more common among rheumatoid patients than in other patients. So for septic arthritis, we need to give them IV antibiotics and then prolonged course of antibiotics, and also they might need joint washout, and then again the supportive therapy with analgesics and spleens. So of course, this patient that I've discussed is gout, patient with gout. Gout, for me, it's gout which presents like this. So a few words on gout. It's due to monosodium urate crystal deposition in joints, bones, and soft tissues. So this gout is usually associated with hyperuricemia. So when the urate levels in the blood is higher, it can get deposited in the joints, bones, and soft tissues. So presentation-wise, the first metatarsal phalangeal joint is a common site for involvement. So they will come with involvement of the first MTP. And then the usual pattern is an episodic monoarthritis. So it's an episodic one. So you have one episode, then after a couple of months, maybe a year, you get the second episode, like that. So usually these episodes, they're short lasting, and they respond very well to non-steroidal anti-inflammatory drugs or steroids. So later on in the disease, you can get a chronic pattern, but or polyarticular pattern in certain conditions, but the usual one is episodic monoarthritis. So what are the predisposing conditions? So when there is increased production of uric acid, that happens with myeloproliferative or lymphoproliferative disease and hemolytic disease. That is when there is a lot of cell breakdown. And then we have the when the clearance of uric acid is less, you can get this gout. So that is chronic renal failure, diuretic therapy, and so on, alcohol. So usually these episodes of gout flares or monoarthritis, there is a predisposing event sometimes, like the patient may have gone to a party and had enjoyed a couple of drinks, or maybe the patient was initiated with the diuretic recently, or the diuretic therapy was increased, like that. There may be a predisposing episode. So these are pictures of gout. So these are tophi. So when uric acid is deposited in soft tissues, you get gouty tophi. So this is a picture of uric acid under polarized microscopy. You can see these crystals, monosodium crystals. So management of gout, so what you have to do is, for the acute episode, you give NSAIDs and steroids, and then you can use colchicine in patients with renal failure, because mostly these gout patients are with chronic renal failure, so you can't give NSAIDs, so you can give colchicine. And so you manage the acute event with these. But if the patients are getting frequent attacks, more than 3 per year, or if they have a persisting risk factor, like chronic renal failure or a myeloproliferative disease, or if they have tophi, we have to give urate lowering therapy, that is allopurinol or febuxostat. So the third case is a 32-year-old male without comorbidities. So this patient presents with back pain with early morning stiffness for 3 years. And he also has alternating buttock pain and also history of heel pain. And there is painful swelling of right ankle joint. And he gives a history of a painful red eye, which was diagnosed as uveitis. So on examination, we find that his spinal mobility is restricted. So Schober's test, I'll show you a picture later on. So in the initial period, the restricted spinal mobility, it's mainly the lateral flexion, which is restricted. Later on, the anterior flexion will also be affected. So then I will show a picture of Schober's test. Okay, this is Schober's test. So what you do is you mark a line between the dimple of Venus, and then you mark 10 centimeters above while the patient is standing erect. And then you ask the patient to bend down without bending the knees as much as the patient can. And then the distance between the two lines should increase to more than 15 in a normal person. So if it does not, that indicates restricted spinal mobility. Then we'll look for sacroiliac tenderness. So you can look for you can exert direct pressure over the sacroiliac joint. So where do you get the sacroiliac joints? So the sacroiliac joints are here, just below the dimple of Venus. So this is another test, Faber's test. So you flex the hip, abduct and externally rotate the hip, and keep the foot on the opposite ankle, and then exert pressure on the knee and also on the iliac crest on the other side, opposite side. And then you can demonstrate sacroiliac tenderness. The other ways to demonstrate sacroiliac tenderness is you can exert direct pressure over the sacroiliac joint, and also you can exert pressure on either side of the iliac crest. So the patient also had evidence of Achilles tendinitis and ankle joint synovitis. So what do you think this patient has? So this patient has a spondyloarthritis. So just a few words on inflammatory back pain. So back pain is a very common thing, but here we have to differentiate whether it's a mechanical back pain or inflammatory back pain. So it's quite difficult to differentiate the two, but these are features that would help us differentiate inflammatory back pain from mechanical back pain. So these are sort of the criteria given for inflammatory back pain. So if the age at onset is less than 40 years, and if it is of a insidious onset, so there is no acute sort of like a event that precipitates the back pain. So it is insidious onset. And also the back pain improves with exercise. And so mechanical back pain, what happens is you get the back pain with exercise and then it improves with rest. But inflammatory pain, it does not improve with rest. More than half an hour. So even the mechanical back pains, they can have stiffness when they rise from the bed, but that usually oligoarthritis. And then this oligoarthritis involves the lower limbs. And then they have dactylitis. So what is dactylitis? So dactylitis is when there is inflammation of the sort of the joints and the soft tissue of a finger. So you get a sausage shaped finger. So the finger is sort of, the whole finger is a single joint. And then you have enthesitis. So we know what enthesitis are. So what are the sites of enthesitis? So they can get Achilles tendinitis or heel pain, and then they can have medial epicondylitis or lateral epicondylitis. Then they can have this enthesitis at gluteus medius insertion around the trochanteric region, greater trochanter. So there can be enthesitis. So there are various forms of spondyloarthritis. So the classic one is ankylosing spondylitis. So we call it the radiographic axial spondyloarthritis because in ankylosing spondylitis, you get this radiographic changes and the spine involvement is very much prominent. And then we have this non-radiographic axial spondyloarthritis. That is when you don't have X-ray changes. In ankylosing spondylitis, we get a lot of X-ray changes. So in non-radiographic, we do not have those. That is a sort of mild form. Then we have the peripheral spondyloarthritis. When there is more peripheral joint involvement rather than the axial involvement. And then we have this reactive arthritis. So reactive arthritis, you have this triad, conjunctivitis, urethritis, and arthritis. So that reactive arthritis. You can also get some skin involvement in reactive arthritis. And then we have arthritis of inflammatory bowel disease. That is arthritis associated with Crohn's disease and ulcerative. That is, we have this other category called so they are at the early stage. They're just they are not evolved into a particular type, so it's undifferentiated. So this is an X-ray showing bilateral sacroiliitis. Here you can see the sacroiliac joints are sclerosed and they're irregular. You have erosions here, and here it's a bamboo spine of ankylosing spondylitis. You can see all the ligament or calcification there. So all the syndesmophytes, the spine is fused. So we can use MRI to detect active sacroiliitis and spondylitis, and also to detect to do in the early disease before the X-ray changes occur. And we can do inflammatory markers. The inflammatory markers are usually high in active disease. And also this spondyloarthritis is associated with Hla B27. So management, so you use non-steroidal anti-inflammatory drugs for the spondyloarthritis, for the spinal involvement. So most of the patients respond to NSAIDs. And then you can use disease-modifying anti-rheumatic drugs for peripheral arthritis like methotrexate, sulfasalazine, and leflunomide. Yeah. For steroids, of course, we use steroids for peripheral arthritis for intra-articular injections, and also we can give systemic for peripheral arthritis. And we can give intra-articular for sacroiliac joints as well. And then in these patients, of course, when the spine is involved from NSAIDs, we have to move on to biologics quickly. So TNF-alpha inhibitors and IL-17 inhibitors. So we have TNF-alpha inhibitors readily available in Sri Lanka. Now we are getting a few IL-17 inhibitors as well, just introduced last year to our country. So other aspects of management is osteoporosis prevention, because these people are more prone to get osteoporosis. So you have to give osteoporosis treatment. And then smoking, quit smoking. It's very important because smoking can actually increase the disease activity and be associated with a poor prognosis. And then we have the surgical intervention for like hip replacement and so on. And physiotherapy is really important. Because this we have to get them to do exercises, regular exercises, to maintain the strength of the paraspinal muscles and the abdominal muscles, as well as the range of motion. Otherwise the spine will become stiff and they won't be able to move. And also physiotherapy for pain relief. So hip involvement is quite common in ankylosing spondylitis. So a lot of patients have hip problems, and later on the disease, a lot of them require hip replacement. So this is a picture showing ankylosing spondylitis, how it's evolved. See, the spine becomes curved, and finally it acquires a question mark posture. Condition to get really at this stage, they can't sleep, they can't keep their head on a pillow. So it's something that we should sort of try and prevent this. So to prevent that, we should diagnose this early and give them proper management early, escalate the management early as possible. So we can prevent them from developing or going into this late stages where they acquire this posture, this fixed posture. So the next case is a 45-year-old gentleman presenting with a painful swelling of left index finger and right middle finger for 1 month. So this patient also has bilateral heel pain. So it's plantar fasciitis and a skin rash. There is scaling of the scalp and abnormal nails. So here, this is a picture showing dactylitis of the middle finger. This is his rash, this is psoriasis, and here the nail changes. So the diagnosis is clear, it's psoriatic arthritis. So the management of psoriatic arthritis is similar. So we give disease modifying agents, steroids for acute disease, mainly intra-articular there, and NSAIDs, and then biologic therapy if they're not responding to the DMARDs, and of course so the examination shows and cervical lymphadenopathy. Her blood pressure is elevated. So here's a picture. She's got the oral ulcers and here a rash and the malar rash. So what is your diagnosis? So it's a case of SLE. So we do the investigations. The full blood count will show anemia and low platelets. There will be leukopenia, mainly lymphopenia. And then you have to do the urine UFR. It's very important here. You look for there may be proteinuria, red cells, red cell casts. And then you have to do the renal function test, SR and CRP, and then ESR will be elevated, CRP may or may not be elevated. So there may be a discrepancy between the ESR and CRP. So that points towards a diagnosis of SLE. And liver function test, we have to do chest X-ray and cardiac assessment because you can get involvement of all the systems. And then the autoantibodies. We have to do ANA by indirect immunofluorescence testing. So we can do the subcategories as well because ANA is not very specific to SLE, but with the above clinical features, of course, a positive ANA gives away the diagnosis that you can do dsDNA, anti-Smith, and ROLA, and U1RNP. These are also ANA antibodies, right? They are subcategories. Then we do serum complement levels, C3 and C4, to look for disease activity. The patient, if they have renal involvement, then we will need renal biopsy. And also we may have to do antiphospholipid antibodies. So SLE can virtually involve all the organs, right? So we have to look for all of them. So we have to screen. So this is a patient again, a malar rash, and these DLE lesions really, and has vasculitis here. I don't know whether you can see that there is bluish discoloration of the toes with vasculitis. So management is according to the organ or system involvement. We usually give hydroxychloroquine because it protects the kidneys, and vitamin D, NSAIDs for pain management and of others, and steroids. And then immunomodulatory therapy depending on the degree and the systems involved. So the drugs that are used as azathioprine, mycophenolate, and cyclophosphamide. There are biologic therapy for SLE as well, rituximab and belimumab. So the next case is a 11-year-old child with fever for 3 weeks. And this is his fever, so it's a quotidian type of fever, daily fevers, high fever. And he also has a rash involving the trunk here. And then he has wrist and ankle joint pain with mild swelling and cervical lymphadenopathy. So this is a fever patient. So first you must exclude infection. I won't go into PUO here. So first exclude infection, and you have to exclude malignancies because they can have similar presentation, right? So it's important that you exclude this. Mainly in malignancy, mainly it's the hematological malignancies. They can present similar with similar picture. So you do a full blood count. You see low HP. The white cell count is high with high neutrophil count and high platelet count. And then liver function disease, there is mild elevation of liver enzymes, hypoalbuminemia, and then the renal functions, they are usually normal. So this patient, so you know the diagnosis, right? This is a quotidian fevers, this rash, and lymphadenopathy. So it's a systemic juvenile idiopathic arthritis, right? So the ESR is usually elevated around 100. CRP also elevated. Then we have to do the serum ferritin. That's grossly elevated, usually in the range of thousands. And ANA and rheumatoid factor is usually typically negative in these patients. So just to mention this, macrophage activation syndrome, because when we are talking about systemic JIA, we have to mention this. This is a very, it's a very life-threatening complication of systemic JIA. So there is hemophagocytosis and the patient becomes really ill. So if there's a sudden drop in platelet, because in systemic JIA, we expect a high platelet count. But here, if there's sudden drop in platelets and HP and white cells also, usually in systemic JIA, you get high white cell count. But if they're dropping, then you have to suspect this. So we do the LDH because there's hemolysis, there's high LDH, and there's a paradoxical drop in ESR. So the patient had high ESR and suddenly dropping, that is, then you have to suspect this. And then you repeat the serum ferritin, then it is massively high. So management of systemic JIA, you give NSAIDs in mild to moderate disease, then steroids, and you can use methotrexate, and of course the biologics, IL-6 inhibitor, tocilizumab, and IL-1 inhibitor, anakinra. So there are biologic therapy. You just have to know that there are biologics therapy for that. And then cyclosporin and cyclophosphamide in case of macrophage activation syndrome. So just a few words on juvenile idiopathic arthritis. Then you have several types of juvenile idiopathic arthritis. So there's systemic arthritis, then there is polyarthritis, the rheumatoid positive or negative one. And then you have oligoarthritis, which is persistent or extended. What happens is sometimes you get oligoarthritis, then it evolves into the polyarthritis. So this oligoarthritis variety, they have the persistent oligoarthritis involvement. And then we have the enthesitis related arthritis, where they have enthesitis involvement. And then psoriatic arthritis, just like in adults, and then you have the undifferentiated one. So management again, NSAIDs, steroids mainly intra-articular preferred in oligoarticular type. You give intra-articular. Disease modifying agents are mainly for polyarticular type. You treat aggressively for polyarticular type because the management is similar to rheumatoid arthritis. There also we can treat with biologics if they are not responding to usual disease modifying agents. And also you can treat, the treatment is similar to rheumatoid. You can try targeted DMARDs like tofacitinib as well. Then uveitis is common. The eye involvement is common with juvenile JIA. So there's a high risk category. So oligoarticular patients, polyarticular with negative rheumatoid factor. Psoriatic arthritis and undifferentiated types are at high risk of developing uveitis. When there is ANA positivity also, they are at high risk of developing uveitis. So in JIA, we need to do ANA. And if the disease onset is at a younger age, then and during the first years of the disease, they are more prone to get uveitis. So we have to send them for screening. So the last case is a 54-year-old lady coming with bilateral knee joint pain for 3 years duration, worsened pain for 1 week, and she has episodic worsening of pain with a history of mild swelling at times, and the pain worsens with activity, worsening with activity, and there is no systemic symptoms. There is reduced range of motion with crepitus. There is tenderness in medial aspect just below the joint line at ansa inversa. So what is the diagnosis in this patient? So there is mild arthritis going on for 3 years duration, and it is a mechanical type of arthritis. So the patient has osteoarthritis. So it's an X-ray of osteoarthritis. You can see the joint space narrowing and the osteophytes here, and there is sclerosis of just below the subchondral sclerosis here. So you can also get bone cysts, but you can't see in this one. And just a picture to show you of a picture of hand osteoarthritis to show you. So we have deformities. Just so a deformed hand doesn't always mean rheumatoid arthritis. So this is hand OA. So you get these nodes, Heberdens and Bouchard nodes, and then there is also here deformity like here. There's joint stiffness. There is squaring here. The thumb is neatly rotated. These ones, this is a extra picture of a hand OA. So osteoarthritis can involve the hands as well. So management, education, patient education is an important aspect. Then we have the non-pharmacologic therapy like exercise, weight loss, lifestyle modifications, and braces, and physiotherapy. Pharmacologic therapy, we give simple analgesics. We try to manage them with simple analgesics as much as possible, or topical analgesics. And then we have NSAIDs. We use the least amount and the lowest dose possible. And you can use duloxetine as supportive therapy, and glucosamine and other supplements can be used. There's not much evidence to support glucosamine therapy, but some patients do respond to this. And then, of course, surgical interventions, joint replacement, and then you can have arthroscopic shavings and so on. So to sum up, how to approach a patient with arthritis. So in history and examination, you have to look at the nature of arthritis. You have to see whether it's inflammatory or non-inflammatory. Then you have to look at the involved joints, number of joints, whether it's symmetric, and what type of joints involved, whether it's small joints of the hand or feet, or whether it's large joints, whether it involves mainly lower limbs, or whether it's the spine, sacroiliac joints, or what. So we have to look at which joints are involved. And of course, then the cause of arthritis, whether it is a persistent one or an episodic one. So episodic is we get it in gout, and then persistent arthritis are the chronic arthritis. And then we look for the involvement of enthesis, and of course the systemic symptoms like in other systemic rheumatic diseases like SLE. Then other system involvement like the skin, the eye, kidneys, lungs, GI, central nervous system. So we have to look for this. And of course, in the management, we need these. So if the patient, because most of the arthritis like the rheumatoid, SLE, they present in during sort of childbearing age. So you have to ask for the plans for pregnancy, whether they are lactating, because the disease modifying agents, some of them cannot be used during pregnancy and lactation. So you have to get these in your histories. And then past obstetric history, because that's important in SLE, because SLE can be associated with antiphospholipid antibodies. So we have this to pay attention to these as well. Then the comorbidities. We need to know about the comorbidities when we are deciding on the treatment, because even for NSAIDs, if the patient has chronic renal failure, we can't use. So we have to look for alternatives. So, and diabetes when using steroids, and liver disease when starting methotrexate. So likewise, we have to look for the comorbidities. And then deformities. We need to look for the deformities in the patient, because then to decide on the spleens and assistive devices and so on. And also the functional status of the patient is very important, because when we are giving management, it's not just pharmacotherapy. It is also, we have to look at the patient's function, and we have to improve the patient's daily activities. So investigation in the lines of diagnosis, then for complications, and for the management decisions, and for the general status of the patient. So you have to have the basic investigations, and then the inflammatory markers. They are important in most arthritis. Then synovial fluid analysis when indicated, and then specific tests according to the differential diagnosis, whether rheumatoid factor, anti-CCP antibodies, serum uric acid, Hla B27 testing, and so on. And then we have the imaging. Imaging can be X-ray, MRI, even ultrasound. So we have to do this. So principles of care, so we have to give symptomatic treatment. So symptomatic treatment is important. So we give analgesics, anti-inflammatory therapy, and then physiotherapy, splinting. So for symptomatic management. And then the disease modification or immunomodulation, that is depending on the type of arthritis. Right. So we've discussed a bit on each type and what to give. So that disease modifying agents and the immunomodulatory therapy will depend on the arthritis and the type of involvement. And then we have to improve the functional status of the patient. So with physiotherapy and orthotics and other assistive devices, and also surgery, joint replacement, and sometimes tendon repairs and so on can be helpful to improve the functional status. And of course, most important, patient education and self-help. We have to educate these patients because they are chronic illnesses. They end up with a lot of disability. They can end up with disability. So we have to educate the patient about the illness. It's very important. And in rheumatoid and other inflammatory arthritis, it's their compliance to treatment is very important. So we have to educate them. Otherwise, the patient, once they get better, they default, and then they wait for the next flare and then only come for the treatment. So it's very important that we educate them. So thank you. Right, if you have any questions, or if you want me to explain any further, anything. Yes. Any questions or anything that you need more clarification on?
Asaka, I am Professor Kudagamana here.
Yes.
There are so many questions being asked in the chat box. If you can...
oh, right. Okay. Sorry. Chat box. So where is the chat box? Hold on. Right. I saw 40 questions, right? Does SLE, okay, so I'll go to the first one. So does SLE patients, even on remission, have a positive ANA, or do they get a positive result only when the disease activity? Usually they have positive ANAs, but with treatment sometimes the ANA can be negative. Okay, so yeah, so usually the ANA is positive. In remission, of course, yes, they can have a negative ANA, but of course the disease activity does not correlate well with ANA level. But dsDNA, of course, does correlate with dsDNA level. Okay. If we diagnose septic arthritis clinically, what is the most appropriate management? Is it joint aspiration or arthrotomy? Clinically, of course, it's like this. If you are very sure it is, then of course you can go ahead with arthrotomy. But in your setting, I think because the arthrotomy is usually done by orthopedics team, of course. So You can go for arthrotomy if you are very sure it is a septic arthritis. But you can do an aspiration in the ward setting in as a basic test. The initial test, that is, rather. So the one is first line drug for rheumatoid arthritis is MTX, and the second line HCQ and sulfasalazine. My mother is suffering from RA, but she has given only analgesics and HCQ. What is the reason for that? So it's like this. It could be that your mother has very mild rheumatoid arthritis. So if it is a very mild rheumatoid arthritis, you can manage with HCQ alone in certain cases. But usually we give methotrexate. So methotrexate is the first line treatment. So that HCQ is only reserved for very, very mild rheumatoid arthritis, or if the patient has been on say disease modifying agents for quite a while and the disease is now very much controlled, then of course we can switch to hydroxychloroquine as a maintenance therapy. Not maintenance, like you can keep the patients on HCQ because it has the least side effects. But the drug of choice is methotrexate because that gives the best results in prevention of joint damage and of But in very mild disease, and if your mother has sort of like, if the patient has contraindications like maybe liver disease, or if she has developed any side effects to these sulfasalazine, leflunomide or the other drugs, then of course we have to manage with the with hydroxychloroquine because it has the least side effects. So it all depends on the patient really. But if we can give methotrexate is the drug of choice. Is joint aspiration used for cytology in septic arthritis? We don't usually send for cytology. We send for full report. We need to look at the neutrophil count and also the culture really. I don't see a need for cytology in that really. Is gouty tophi a kind of subcutaneous nodules? Yeah, it is felt like nodules, yes. So tophi can occur in subcutaneous tissue in relation to tendons, in relation to bones. So it can occur anywhere. So in all tissues associated with joints. You feel it when you touch it, you feel it, and they look sort of like yellowy, chalky sort of appearance. So if by accident, if it gets pricked, you get this chalky sort of material coming out. Is morning stiffness a feature of spondyloarthritis? Morning stiffness is a feature of inflammatory arthritis. So morning stiffness, we have to take as significant morning stiffness is when you have morning stiffness lasting for more than 30 minutes really. So morning stiffness of the spine is a feature of spondyloarthritis. Morning stiffness of your hands and say the proximal interphalangeal joints or the MCPs, then that is a feature of peripheral arthritis. So any inflammatory arthritis gives rise to morning stiffness. So if you have a morning stiffness of your hands, most likely rheumatoid if it's associated with swelling also. Is coccydynia related to spondyloarthritis? No, that is a different pathology. Coccydynia is not an inflammatory condition. That is due to the coccyx, the mobility of the coccyx, and it's not related to spondyloarthritis. So giant cell arteritis is, so you want to know about giant cell arteritis. It is a vasculitis. It is a large vessel vasculitis. So you usually get in elderly patients. So that you can get sort of an arthritis or arthralgia with giant cell arthritis because it is associated with a condition called polymyalgia rheumatica. So polymyalgia rheumatica is a condition where you get this shoulder and neck stiffness. It may be associated with shoulder arthritis or soft tissue inflammation. There can have this tendon and bursitis involving the neck and shoulder region, or maybe the pelvic region as well. So giant cell arthritis is a type of vasculitis. It's a large vessel vasculitis that occurs in elderly people, which threatens the sight of the patient. So we need to treat aggressively. In rheumatoid arthritis, can COPD, fibrosing alveolitis like pulmonary condition occur? Yes, you can get interstitial lung disease in rheumatoid arthritis. So if you treat the rheumatoid arthritis well early on, and if you control the disease early, then the developing of this interstitial lung disease is also less. So they develop certain like several types of this interstitial lung disease. Yeah, so it's not COPD, like there is no rheumatoid arthritis does not give rise to COPD, but it does give rise to interstitial lung disease. That fibrosing alveolitis, we don't call fibrosing alveolitis anymore. So it is interstitial lung disease, either UIP or NSIP, we call them. Of course, respiratory. So those interstitial lung diseases, we call it. So that can occur with rheumatoid arthritis. What is the use of spleens in rheumatoid arthritis? So we use spleens in several ways. We use spleens to immobilize the acutely painful joints. So we can use resting spleens. That is to immobilize acutely painful joints. And then also we can use spleens to prevent deformities, like to stabilize the joints. So those are active spleens. So we preserve the mobility of the joints while wearing the spleen. So we can use the joint, but then there is some external protection for the joint. So we can use for both reasons. Can we detect monosodium crystal in the synovial fluid? Yes, of course, that's what we do. So when we aspirate the joints, then we send the crystals. We have to send a fresh sample to the lab, so they have to look under the polarized microscope to detect the crystals, really, because we can't differentiate. We can see crystals through the normal microscope, but we can't really differentiate between which crystal it is. So for that we need polarized microscopy. So we have to, in gout we can see this, if we can see the monosodium urate crystals in the synovial fluid. Are syndesmophytes pathognomonic for Ankylosing? Yes, syndesmophytes are pathognomonic for Ankylosing. You get so they have features, right? Because sometimes this bridging osteophytes, they can look similar, but then syndesmophytes are sort of a characteristic of all spondyloarthritis. Not Ankylosing, all the spondyloarthritis. Even with psoriatic arthritis, you can get syndesmophytes. But you can get similar sort of picture in other conditions. There's this condition called diffuse idiopathic sort of. So I don't think you need that. Or anyway, we'll say syndesmophytes are characteristic of spondyloarthritis. So can Hla B27 positivity be used as a diagnostic test in patients who present with signs and symptoms of spondyloarthritis? Yeah, it is a supportive one. So we have this criteria, but if you have a positive Hla B27, that is very supportive of the diagnosis of spondyloarthritis. Can plantar fasciitis be seen in RA2? Yes, of course, plantar fasciitis, you can get plantar fasciitis in rheumatoid arthritis. You can just get plantar fasciitis without any arthritis. It's a common condition. How can we manage a rheumatoid arthritis patient with increased WBC count and low hemoglobin? Can we give him DMARDs? So we actually don't treat the blood counts, right? If the patient has active disease, we can give DMARDs. So high white cell count is not a contraindication for disease modifying agents. So, but we have to see how high the white cell count is, whether the patient has any other condition which is causing the high white cell count. But rheumatoid arthritis, and if the patient is on steroids, you can get a high white count. But if the patient has very, very high white counts, of course, you need to see if the patient has any other condition, like a hematological malignancy or so on. So in that case, of course, then you have to see whether that treatment would be then we have to decide which DMARDs to give, safest DMARDs to give with co-therapy. So anyway, low hemoglobin is not a contraindication for disease modifying agents. So we have to find the cause for the low hemoglobin. So low hemoglobin can be due to the chronic disease, the inflammatory disease itself. So that will of course respond to better management of the disease. So once we bring down the inflammation, once we bring the disease under control, then of course the platelet count will, the hemoglobin will improve. So we have to, in these condition, in this situation where the white cell count and the low hemoglobin, then we have to see why the patient has a high white cell count. So if the cause of the white cell count is not a contraindication for the disease modifying agent, then of course we can use. Can peripheral SPA only cause knee arthritis? Yes, peripheral spondyloarthritis can present with knee arthritis alone. Yes. So we have usually peripheral spondyloarthritis involves the lower limbs. So knee arthritis can be a presenting feature. Finger locking symptom of arthritis. Okay, so that is finger locking is we call trigger finger, that is stenosing tenosynovitis. So that usually it can occur with arthritis, but many of the instances it is not associated with arthritis. So you can get trigger finger in patients with inflammatory arthritis, but trigger finger alone is not a feature of arthritis. So a lot of patients with diabetes are more diabetic patients, they are more prone to get trigger fingers, so like that. And patients who use their fingers very so people who use this manual work, they can get this trigger fingers. So there are other reasons. Is Hla B27 specific for spondyloarthritis or whole spondyloarthropathy? Can it be used to diagnose spondyloarthritis specifically? Oh, no. Hla B27 is like you get in normal patients as well, but people with positive Hla B27 are more prone to develop spondyloarthritis. So about 95% of the spondyloarthritis patients would have a positive Hla B27. That's the way. So it's not a sort of like sort of diagnostic test. How does morning stiffness occur in arthritis conditions, and how can we diagnose the condition depending on duration of symptoms? So it's usually morning stiffness indicates inflammatory arthritis, because inflammatory arthritis worsens, the symptoms worsens at rest, right? So for morning stiffness to be significant, we take it that the patient is feels stiff more than half an hour. It's not an absolute thing. Even patients with osteoarthritis can have the stiffness. Patients with hand osteoarthritis, they will say their hands are stiff all throughout the day. So you ask them, do you think that your hands are more stiff in the morning? Then they might say no. Like morning stiffness is like there's either worsening of the stiffness in the morning, or the stiffness only is there in the morning. So that is just a feature of inflammatory arthritis. So when we ask the history, we have to differentiate now whether it is inflammatory or non-inflammatory. So these are supportive features to indicate inflammatory arthritis. So in non-inflammatory arthritis, usually the stiffness lasts about 5 to 10 minutes. The patient says, once I move my joints, it's no longer stiff. Do we use leflunomide in ward setup usually? If so, what are the indications to use? Leflunomide, here you use leflunomide in rheumatoid arthritis, in spondyloarthritis, like in psoriatic arthritis. So yeah, leflunomide is used even for JIA. You can use leflunomide. So it is a say now it's a strong disease modifying agent. So if now sort of like if we diagnose a rheumatoid arthritis, and if the patient has contraindications, methotrexate, so leflunomide is the drug that we consider starting next. because it's a quite good drug. Can cervical spine, hip joint and pelvic girdle be affected in rheumatoid arthritis without involving small joints? It's quite unlikely. Usually, cervical spine gets involved in hip and pelvic girdle, they get involved in rheumatoid, but usually in rheumatoid you have the small muscle and other peripheral joint involvement. Giant cell arthritis always associated with polymyalgia rheumatica. No, giant cell arthritis is not always associated with polymyalgia rheumatica. It is sometimes associated with polymyalgia rheumatica. So there is an association between the two. So it does not have to have that polymyalgia rheumatica. Is Still's disease a type of JIA? So yes, systemic JIA is juvenile Still's disease. So we have the adult Still's disease as well. It is quite rare. But systemic JIA is not that rare. So Still's disease is systemic JIA. Is Still's disease a form of juvenile idiopathic arthritis? Yes, I answered the question there earlier. So Still's disease is systemic juvenile idiopathic arthritis. So I said there are several types of juvenile idiopathic arthritis, right? So Still's is the systemic type. And adults also can get Still's disease, and it's quite rare. So adults will also present with a similar picture. They will present with the pyrexia of unknown origin. The fever will go on and on and on. Arthritis may not be that prominent. So they may have wrist joint involvement or hip joint involvement. So usually it's sort of like 1 or 2 joint involvement. And then the PU and then the findings, the blood findings and all that are similar to that of systemic JIA in kids. Does polymyalgia rheumatica only occur in those more than 50 years? Yes, it's usually for people more than 50 years of age. You don't see it in younger patients, but rarely you can. But mostly it's above 50, so it's a diagnostic criteria. So we usually don't consider polymyalgia rheumatica as a differential diagnosis in younger ones. What are the subtypes of JIA which cause permanent joint deformity? So mainly it's almost like the oligoarticular, psoriatic arthritis and polyarticular types. They can cause permanent joint damage. Even systemic JIA can cause permanent joint damage. So you need to give them proper treatment. So mainly the key factor in these arthritis is you treat them early. Early treatment is necessary to prevent permanent joint damage. Is rheumatic fever a predisposing factor for osteoarthritis? Not really. Rheumatic fever, the arthritis that you get with rheumatic fever is not a sort of a chronic arthritis. It's a mild sort of like it's an acute arthritis, but it does not cause joint damage. So it's not a predisposing factor for osteoarthritis. Are joints tender in osteoarthritis? Yes, joints can be tender in osteoarthritis, but not severely, not as tender as you see in inflammatory arthritis. So when you're checking for joint tenderness, you exert only very mild pressure. So the pressure that you apply is like when you push, like when you press, only the upper third of your nail should become pale. Right, so only very mild pressure. So that is how we take significant joint tenderness. What is the best investigation to confirm flare of SLE? So best investigation, we can't really say like that. So it's a supportive thing, right? So you look, there are criteria. So there are things that we look for to assess whether there is a flare. So there are certain features that we look for. So we see whether the patient is developing new features or whether the associated, whether already existing ones are becoming worse. So like if the patient did not have hair loss, then suddenly start to lose hair, then that is suggestive of a flare. So likewise, there are sort of we look at the patient as a whole. There is no single investigation. We have to look at the clinical features, and whether they are new. So we have to compare whether the patient like the previous features and now. Like usually we consider take 2 weeks, right? So previous to it, whether there's new involvement or whether there's new worsening of the present the previous symptoms. And also then we look at the inflammatory markers. The ESR will be high, and then complement levels are helpful to determine a flare. So we use complement levels sometimes to differentiate between this fever due to infection and to see if the fever is due to the disease flare. So to see if so complement levels can be used, but complement levels alone is not what we use. We look at the patient as a whole, like we use the history, the examination, and the other investigations as well. Can MTX given in no way? It's like this, right? It's not, methotrexate is not indicated to treat osteoarthritis, right? But there is a condition called erosive osteoarthritis, but there are certain research going on for methotrexate in this erosive osteoarthritis, because now we believe that there is some inflammatory condition component of osteoarthritis as well, right? But don't go and say that this in the exam. For your exam purposes, this methotrexate is not given for osteoarthritis, right? But really, in certain conditions, if there's a lot of inflammation, it can be tried. There are some certain research going on. But they are not conclusive, so they are not in the guidelines yet. So for your purposes, methotrexate is not currently used for osteoarthritis. Is gonococcal arthritis a form of reactive arthritis? No, gonococcal, it's a septic arthritis. You get with the, you can isolate gonococca in the fluid. Is rheumatic arthritis, in rheumatic arthritis, if lungs are involved, what are the features we could find? You mean rheumatoid arthritis, is it? Or rheumatic? I think this must be rheumatoid. So rheumatoid arthritis, you can have pleural effusions. So signs of pleural effusion. And then you can have interstitial lung disease. So you get fine and inspiratory crepitations in interstitial lung disease. So interstitial lung disease, you can get this, there are other types like you can get bronchiolitis obliterans like picture. So sometimes you may hear wheezes, but mainly end inspiratory crepitations, fine end inspiratory crepitations if it is interstitial lung disease, and pleural effusion, signs and symptoms of that is reduced breath count and stony dullness and so on, reduced lung expansion and so on, if it is pleural effusion. Of course, nodules, of course, we can't get any features in auscultation or examination. It's incidental, you see them in when you do HRCT and all. Osteophytes seen only in osteoarthritis. Osteophytes are seen in osteoarthritis, really. So thing is, when you have inflammatory arthritis, then there's joint damage. So you can get secondary osteoarthritis in these damaged joints. So you can have osteophytes there as well. RA can affect pelvic girdle. Yeah, you can have hip involvement with rheumatoid arthritis as well. Really, you can get sacroiliac involvement as well. But they're not typical features. Hip, of course, yes, but this sacroiliac you can, but it's not typical feature. Is a raised ESR a feature of osteoarthritis? You don't usually get a raised ESR for osteoarthritis, but with flares you can get a mildly elevated ESR. Can POSI, JIA and psoriatic arthritis initially present as monoarthritis? Yes, they can present with monoarthritis and later on develop to polyarticular arthritis. In some MCQs, they ask what are the characteristic features of rheumatoid arthritis. What does it mean? So the characteristic of rheumatoid arthritis is symmetric small joint involvement, then the MCP involvement, then you have this erosions. So I think those are the ones they must be targeting at. So metacarpopharyngeal joint involvement is quite a typical feature of, characteristic feature of rheumatoid arthritis. So those must be. Does SLE patients have on remission? A positive I did. Madam, what are the treatment options for Achilles tendinitis? So Achilles tendinitis, mainly you give NSAIDs, you can give short course steroids. So Achilles tendinitis, you have two types of tendinitis, right? You can have the enthesitis, that is the insertional tendinitis, and then the tendinitis, the inflammation of the synovial sheath and the body of the tendon, right? So for enthesitis is usually associated with spondyloarthritis. So the other one is mainly mechanical type sort of tendinitis. So you can treat with NSAIDs and sometimes a short course of steroids. Then physiotherapy, you can give a little bit of a muscle relaxant to until the anti-spasmodic to sort of prevent muscle spasm there to help heal. So those are the things that can be done. So physiotherapy plays a big role there. You can, if they are not responding to NSAIDs and a short course steroids, you can go for physiotherapy. Injection, of course, is not very advisable here. Only in very some occasions we decide on steroid injections, but it's not typically done. If the joint is painful, swollen, tender, what further features need to be looked to differentiate degenerative inflammation and inflammation? If the joint is painful, swollen, and tender. So this could be, if the joint is painful, swollen, and tender, then it's either a flare of osteoarthritis. That is the only time that you can get a painful, swollen, tender joint with degenerative arthritis now. So you have to get the history now, whether this was like that, whether the patient has a chronic ongoing persistent mechanical type of a pain, like that. And then if there's florid inflammation occurs, then it is most likely to be inflammatory arthritis. In osteoarthritis flares, you don't get this florid inflammation. So you of course ask the history, see the cause of illness, so whether that patient had sort of mechanical pain going on, and whether this was this acute worsening. And then we can of course if there's a effusion, we can aspirate and see to see whether there's sort of inflammation there. Likewise, then we can do the inflammatory markers and so on. In early rheumatoid arthritis, for the management, do we start multiple DMARDs at once? Do we try them one by one? So initially, sort of now we have sort of changed. Early days, we used to say start with all DMARDs together. But now the practice is to start on one DMARD first. So the first DMARD to start is methotrexate, right? So we start on methotrexate and then escalate it quickly. Like we start, say the starting dose is usually around 10, then you escalate it to 12.5 or 15 in 2 weeks, like that. In 2 weekly intervals, you keep escalating the therapy. And see the patient whether the disease is coming under control. And if we can't control with one disease modifying agent, then we add the second, then we go on to add the second one and see. And then the third, and then usually hydroxychloroquine, and in that case we can add hydroxychloroquine, then we don't waste much time on that ideally. Then if still not responding by 6 months, we have to go on to biologics. But here, due to unavailability and the cost, of course, we don't do that. Then we try to manage with DMARDs, sort of the synthetic DMARDs, the ones that we use. So we use methotrexate and leflunomide, sulfasalazine. So usually first one to start is methotrexate. If it's contraindicated to methotrexate, you start leflunomide. So methotrexate, we add on sulfasalazine and see whether it's controlling. So we have to, the thing is, like when we are giving methotrexate, we have to give a good dose. So give 10 milligrams of methotrexate, and you can't say the patient is not responding. So you have to go up on it. You have to go up to, so around 20 to 25 would be the maximum dose. So usually our people are not that heavy. So 20 would be the maximum dose. So we go up to 20 and see if it's controlling. If not, you add on the sulfasalazine. and yes, so then the biologics and so on. Is it okay to use crepe bandage joint immobilization in OA? Yes, you can use crepe bandage when there is a flare, but long term we don't immobilize, because then that can lead to this quadriceps weakness. So we have to maintain the range of motion and muscle strength now. So we use for in acute flares, we can immobilize the joint in acute flares. What is the best investigation to confirm SLE flare? SLE flare investigation, best investigation. So is this an MCQ really? Then of course I'd say if it's an MCQ, maybe the complement levels, C3, C4. Otherwise, SLE flare is usually, we look at it as a whole, right? So if there's renal involvement, we see whether there's worsening of proteinuria, or whether there is new hematuria, or whether the renal functions are deteriorating. If likewise, we look at the clinical features, then the other investigations, and then serum complement levels are helpful to see. So if this is an MCQ, if they're asking for the best investigation, I think they're looking for serum complement levels, C3 and C4. Since dsDNA is a subtype of ANA, can we take raised ANA as a feature of a flare? No. Usually ANA, it's a bit conflicting thing, but ANA titers, of course, we can't say it corresponds with disease activity. It's not taken as if it is. Because only a few number of patients would have a positive dsDNA. But dsDNA levels are not like usually you get a positive dsDNA in patients with renal and CNS involvement. So in these patients, we can use dsDNA as an indication of sort of feature of a flare. Levels, sort of dsDNA levels correspond to flares or disease activity. Yeah. Can ankylosing spondylitis cause knee pain with persisting morning stiffness for 1 to 2 hours? Yes, of course. Morning stiffness 1 to 2 years. Usually inflammatory arthritis patients, they say, the rheumatoid arthritis patients, they say my joints feel stiff till about 9 o'clock in the morning. So Ankylosing patients also can have, because they have inflammatory arthritis, so they can have morning stiffness for 1 to 2 hours. Yes. What are the characteristic features of seronegative spondyloarthritis? Characteristic features that we discussed. So the main feature is involvement of the axial spine joints, mainly the sacroiliac joints. Then you have enthesitis, and then oligoarthritis, mainly involving the lower limbs. And then I can have dactylitis. So these are characteristic features of spondyloarthritis. What is the place for blood culture in septic arthritis? What is the investigation of choice? So investigation of choice is joint fluid analysis with the culture. Yeah, you have to do blood cultures as well. You take blood cultures as well as joint fluid. Is allopurinol contraindicated in flare of gout? It's like this. If the patient is already on allopurinol, we continue it, but we don't start allopurinol while the patient is having a flare. First, we have to bring the inflammation down. So first we give NSAIDs or steroids, and then start allopurinol, and then cover the initial period of allopurinol treatment with either steroid, colchicine, or an NSAID. Right, then we continue the allopurinol alone, because at the initiation of therapy you can have a flare. Why does pain arise in inflammatory arthritis at night? That of course I do not know the answer to. I'm sorry, but what happens is with rest you get pain. So that is why I am unaware to answer that. I'm really sorry. I don't know the reason why, but because inflammatory arthritis pain is supposed to worsen at rest. So at night your joints are at rest, so you get worsening. Is there evidence for using a combination of DMARDs to achieve remission in rheumatoid arthritis than monotherapy? It's like this, we try monotherapy because we try methotrexate initially, and if the patient is not responding to that, then we go on to add-on therapy with sulfasalazine, or you can really combine leflunomide also with methotrexate. But yeah, so we add on or we give combination therapy when we can't manage the disease with methotrexate alone. So there is evidence that multiple therapy or combination therapy helps the treatment or help the control of the disease. Can calcification of spinal ligaments happen in RA? Usually not so. It's not characteristic of rheumatoid arthritis. Madam, can GCA cause weight loss? GCA can cause weight loss because GCA, you can have a lot of systemic symptoms. You can have fever, you can have malaise, lethargy, weight loss, yes. Can polymyalgia rheumatica occur in people below 50? It's not common. It can really, but not in very young. But usually we don't consider polymyalgia rheumatica in young people, but around 40s, 50s. 50s, it's included in the diagnostic criteria. It's above 50, but this is human body, so we can't really draw lines like that. But it's less likely. You usually don't consider. Can rheumatoid arthritis cause bone cysts? Usually rheumatoid don't cause bone cysts. It's osteoarthritis which causes cysts. But if the patient has secondary osteoarthritis, you can get bone cysts. If morning stiffness presents more than 30 minutes, can tell that arthritis be osteoarthritis or RA. So we can't really differentiate osteoarthritis from rheumatoid from the morning stiffness alone. Patients with hand osteoarthritis sometimes complain that their hands are stiff all day long, right? So there is no worsening of the stiffness in the morning. So we take morning stiffness as significant if it lasts for more than 30 minutes, right? So it supports a morning stiffness lasting for more than 30 minutes supports the diagnosis of inflammatory arthritis. To differentiate between osteo and rheumatoid arthritis, you have to look at all the features. So what joints are involved? So in hand osteoarthritis, you get distal interphalangeal joints and proximal interphalangeal joint involvement. In rheumatoid arthritis, you get metacarpophalangeal joints and proximal interphalangeal joints. So if the metacarpophalangeal joints are involved, it's more likely to be, mostly rheumatoid. If the distal interphalangeal joints are involved, then it's less likely to be rheumatoid because you rarely get involvement of the distal interphalangeal joints. If the joints are really swollen, there's soft tissue swelling, not bony swelling, there's soft tissue swelling and very tender, then it's more suggestive of rheumatoid arthritis, because in osteo you get tender joints, but they're not that tender, they're not that florid. The inflammation is not that florid. The swelling, there is swelling, usually that is bony swelling. There may be mild soft tissue swelling, but in rheumatoid you get a big boggy sort of a swelling. So you have to touch the joints. And so diagnosis of this arthritis, it's a sort of a combination thing. There is no specific test or specific speech. You have to take it as a whole. You have to listen to the patient. So it's really important you get the history from the patient herself. You listen. You have to pay a lot of attention to the history, what the patient says, and then examine the joints. You have to palpate all the joints and see. Can rheumatoid factor be positive? Can rheumatoid have other subtypes of J other than polyarthritis? It can be, because sometimes what happens is the patients present with oligoarthritis, and then it can go into this sort of the polyarticular type. So in these patients, it can be. What is the purpose of reducing stress on joints in rheumatoid? So what happens is, what is the purpose of reducing stress on joints in rheumatoid arthritis, right? So Here, what happens is when you have inflammation of the joints, the joint capsule and the ligaments and the tendons which are holding the joint together in place are loose, right? So when you put pressure, then they can get subluxed and the joints can get damaged. So you have to protect your joints. So that's why we don't put stress on the joints, right? Can bone cyst formation seen on RA? Usually not. In acute attack of gout, what happens in serum? What happens to serum uric acid levels? In acute attack of gout, what? It can be normal. In some people, the uric acid can be normal during acute attack. So sometimes we advise if the uric acid is normal during the acute attack, we have to repeat the uric acid later on, right? If you are suspecting gout, it is not normal always, right? Sometimes it can be normal. What are the differential diagnoses for high ESR? More than 100. You mean the rheumatological diseases? You sometimes rheumatoid arthritis, SLE, polymyalgia or vasculitis. So these conditions, you can have very high ESR. Even in spondyloarthritis, you can get very high ESR. There are some category of patients who get very high ESR above 100. Can several of these diseases coexist? If patient complains of joint pains at morning and night with stiffness throughout. Patient complains of, but can several of these diseases coexist? Yes, several of these diseases can coexist, like rheumatoid arthritis, osteoarthritis, and then spondyloarthritis with osteoarthritis, like that. Okay. Several types of these coexist. So if patient complains of joint pains at mornings and at night with stiffness throughout. Yes, osteoarthritis and rheumatoid arthritis can, rheumatoid or inflammatory arthritis can coexist. What is the best investigation to diagnose and confirm ankylosing spondylitis with positive X-ray features? Excuse me. So, best investigation. So if they have X-ray features, then you've got your X-ray features. So you can confirm your diagnosis with X-ray features really. So if they have sacroiliitis, bilateral sacroiliitis, Ankylosing, and then the syndesmophytes. So these are features to confirm the diagnosis of spondyloarthritis. So like ankylosing spondylitis. What is the probability of developing psoriatic arthritis in a patient with dermatological manifestation of psoriasis? It's like this: if the patient has plaque psoriasis, they are more likely to develop psoriatic arthritis, and if they do have nail changes, then they are more likely to develop psoriatic arthritis. Is excessive caffeine intake is a risk factor for osteoporosis? Yes. Coffee intake is a risk factor for osteoporosis. Can there be instances where blood culture negative in septic arthritis? Blood culture may be negative. Yes, can be negative. In a patient previously diagnosed with SLE, does lymphopenia confirm a flare in disease? In a patient previously diagnosed, yes, because lymphopenia, there are certain features that we get with SLE flares, right? Hair loss, then new skin lesions or new oral ulcers, and then lymphopenia, mainly if the lymphocyte count is less than 1,000, then like it's like this. We give a sort of, we don't take just one feature to confirm a flare. We look at the features together, right? Actually, there is a sort of a score that we do with considering all the features to decide whether the patient is in a flare. So lymphopenia is one of them. So in disease flares, you can get lymphopenia. In rheumatoid arthritis, can there be scleritis other than anterior uveitis? Rheumatoid, yes, we get scleritis and episcleritis. with rheumatoid arthritis. Uveitis is associated with the spondyloarthritis. Is locking finger a danger sign? Took treatment 11. So my mother had RA and took treatment 11 years now, and she gets locking thumb and on and off. Does it need immediate intervention? No, not really. It's probably due to trigger thumb, or what we call stenosing tenosynovitis. It does not indicate a flare. It's just a isolated sort of like it's a different pathology there, what we get in stenosing tenosynovitis. So you can try with some analgesics, and so massaging some local analgesics over the nodule, and then you can try with the injection. It settles with injection, steroid injections to the synovial sheath. What is the relationship between writer's syndrome and reactive arthritis? All right. So writer's syndrome, we don't use the term writer's syndrome because that was this writer's was a German scientist, so was involved in these the camps where the Jewish were kept. So we don't use the term writers anymore because we don't use his name anymore. So reactive arthritis. So reactive arthritis in spondyloarthritis is the writer's syndrome, right? But there's this other viral reactive arthritis, or the reactive arthritis, other types of reactive arthritis that you get, like post-streptococcal reactive arthritis. That is not the writer's syndrome. That is not the spondyloarthritis, the writer's syndrome. Writer's syndrome is a type of spondyloarthritis for which we call reactive arthritis. Right now it is called reactive arthritis. But there are other reactive arthritis. It's a bit of a confusion, right? But there are other reactive arthritis which are not spondyloarthritis. These reactive arthritis are different. So we name them as post-streptococcal reactive arthritis, viral reactive arthritis, like that. So the features for those post-streptococcal reactive arthritis is different. It's not a part of writer's syndrome. It is not writer's syndrome. So writer's syndrome is now called reactive arthritis, and it is categorized under spondyloarthritis. That is the one where you get the triad of oligoarthritis, conjunctivitis, and urethritis, right? How do clinically differentiate Achilles tendonitis from plantar fasciitis? So you palpate and see where the maximal tenderness is. You can hyperextend your toes and see whether there is tenderness, or with plantar fasciitis it worsens, and then you can actually exert direct pressure and see where the actual tenderness is, whether it is in the tendon, or whether it's at the enthesitis site, or whether the plantar fascia is whether the tenderness is more in the plantar aspect. So it's sometimes it's difficult because some patients, what happens with pain is, with soft tissue problems is, when you get pain, then it's sort of you get this pain in surrounding structures as well, right? So sometimes it is a bit difficult to differentiate the two, and sometimes two can coexist. What is the definitive treatment for stenosing tenosynovitis? So it's like this: you try with non-invasive treatment, then you try injection. Sometimes the first they respond to one injection. Sometimes you can repeat the injections and see. If it is not responding to those, then you can surgically release it. That is the final. What drugs in SLE are safe in pregnancy? So hydroxychloroquine is safe in pregnancy. Azathioprine can be used safely in pregnancy. So those are the drugs that we usually use in pregnancy. So in SLE patients, you have to plan their pregnancy, right? You have to educate the patients, and of course steroids. Steroids can be used with caution in pregnancy, right? So you have to really plan their pregnancies. And the patient has to be in remission to go for a pregnancy. What are the diseases with migratory polyarthritis? So migratory polyarthritis, you get with SLE, you can get this migratory polyarthritis. Then features, sometimes early rheumatoid can be migratory. It's migratory like, you get this episodic, like palindromic sort of. You can get in early rheumatoid arthritis, and you can get a palindromic rheumatoid arthritis. And then even with sarcoidosis, you can get a sort of a migratory one. Then migratory arthritis is common in rheumatic fever in children. So those are the types really. What is the best drug to start next after MTX in RA? Is it HCQ or sulfasalazine is the next drug to start, right? But if you can't start on sulfasalazine, you can give hydroxychloroquine. Hydroxychloroquine is a weak anti-rheumatoid drug, right? The main use of hydroxychloroquine is with SLE. Its main use is with SLE, but you can use hydroxychloroquine with, like, it can be a supportive additive therapy. So if the patient has rheumatoid that needs to be brought under control, then after MTX, after the maximum dose of MTX, you add on sulfasalazine. Do we go triple therapy for DMARDs before starting biology? Yes, ideally we have to. So in our other countries now, they say double therapy is enough. That is methotrexate and sulfasalazine. You try with those, and if the patient is not coming into remission or low disease activity, then of course we have to go for biologics. But here we can try with the hydroxychloroquine because there is some additive support. And as biologics are not so widely available. Is rheumatoid factor always positive in rheumatoid arthritis? No, there's a seronegative rheumatoid arthritis. No, so rheumatoid arthritis we don't diagnose with the rheumatoid factor. Rheumatoid arthritis we diagnose with the clinical features, the pattern of joint involvement, right? So there is a fraction of patients who are rheumatoid factor negatives. We call them seronegative rheumatoid arthritis. Don't mix up seronegative spondyloarthritis with seronegative rheumatoid arthritis. Those two are two different entities. Seronegative rheumatoid arthritis is rheumatoid arthritis. The disease is rheumatoid arthritis. It is just that the rheumatoid factor is negative, right? So spondyloarthritis, we used to call it the seronegative arthritis. So that is spondyloarthritis. That is not seronegative rheumatoid arthritis. That is spondyloarthritis, right? What are the NSAIDs and steroids commonly used in gout flare-up? So NSAIDs, we can use any NSAIDs can be used, but naproxen, it's like this. NSAIDs, there are some NSAIDs have more analgesic effect, and some NSAIDs have more anti-inflammatory effect. For gout, we usually use naproxen, which has more anti-inflammatory effect. If the patient can sort of tolerate that, we use NSAIDs with more potent anti-inflammatory effect. So like naproxen and diclofenac, and then toricoxib. These drugs have more strong, potent anti-inflammatory effect, right? In a sense, steroids, of course, you can use our good old prednisolone for this gout. Are NSAIDs not effective for severe systemic JIA? If the patient has severe JIA, then of course we have to consider other treatment. We can't just manage with the NSAIDs. Is there any role of dietary modification in the management of rheumatic disease? So the question is there any role of dietary modification in the management of rheumatic disease? So usually what we advise is to have a balanced diet. And of course, high sugar intakes are associated with the poor disease outcome. So better to limit or keep your sugar intake to a safe level. So there is no other dietary modifications really, but you need to have a balanced diet. It's good to consume omega-3 fatty acids. They're supposed to be, they are sort of helpful. Other than that, no specific diet required. All right, I think that's all.
Yeah, I think it's now it's past 10 o'clock, Asanaka. So thank you
Alright,
very much on behalf of PeMSAA for your time and your excellent talk today. I'm sure students would have enjoyed it very much. And there were so many questions that you answered. At the whole of 1 hour, you've been answering the questions. So thank you very much again. And we'll see you again. Thank you very much again.
Okay, you're welcome,
Okay.
Doctor.
Okay.
Yeah, bye.